once again, thanks for the invitation to this this academic series. So I just want to share with you some of the ideas that we have in terms of trying to pilot a diabetic retinopathy screening program using innovative ways by the artificial intelligence, starting with Lagos. As we're all aware that diabetes mellitus is one of the major causes of visual loss globally, and it is projected that about half a billion people in the world have diabetes, and in the next 2 decades is going to increase by at least 46%. And 3/4 of these diabetes are living in the low and middle income countries of the world, which means including Nigeria. And the disease in 2021 only, it has caused over 6 million deaths. And there are over 4 million people that have visual loss from diabetes currently. Looking at diabetes in the sub-Saharan Africa, it has an average prevalence of 4.7%, but it varies widely across different countries. In Nigeria, it's definitely higher than this. We'll see it in the subsequent slides. But what is more worrisome is that if you look at the picture globally in the sub-Saharan Africa, global picture, the sub-Saharan Africa is projected to have more rapid increment in the next 2 decades, with increment of about 100%. So as ophthalmologists, all we know that the problem with diabetes is that it causes retinal deposits and bleedings, which ultimately, if not addressed, will result to irreversible blindness. The prevalence of diabetes, as I've mentioned, in Africa is about 4.7%, and at least 1/3 of people with diabetes have diabetic retinopathy. But even worrisome is that 10% of people that have diabetes have sight-threatening diabetic retinopathy, which means they can go blind at any time if measures are not taken immediately. This is the prevalence of diabetic retinopathy globally. And again, not only that, the burden of diabetes in itself is likely to increase more rapidly in sub-Saharan Africa. The prevalence of diabetic retinopathy, as from the projections estimated in 2020, Africa has the highest, with about 36% of people that have diabetes have some degree of diabetic retinopathy. So typically, we know that people with diabetes from normal retina, they can go in to have this complication that can result in blindness. And to prevent this happening, people have to be identified early enough through screening program, and then intervention has to be made to prevent them from going into this complication, which often is irreversible. So the WHO has published several studies that has demonstrated that diabetic retinopathy screening preserve the vision of people with diabetes in many communities. However, there are serious challenges to the implementation of diabetic retinopathy screening, especially in developing countries. Now, these are some of the main challenges. Number one, as I've mentioned, that there are increasing number of people with diabetic retinopathy because of increased number of diabetes among in many developing countries, and also increased number of poorly controlled diabetes, which results in more increased number of people with diabetic retinopathy. And it is projected that in the next 2 decades, the number of people with diabetic retinopathy is going to increase by over 143%. Now, another very important problem is that there are inadequate number of health personnel, especially ophthalmologists, that will be the ideal people to be able to screen diabetes to identify diabetic retinopathy. And looking at in sub-Saharan Africa, you will realize that the average number of ophthalmologists per 1 million population is 2.5. The global average is at 7.5. So you could see that definitely there's so much dearth of ophthalmologists. There are no ophthalmologists to be able to conduct diabetic retinopathy screening program. As such, there are minimal or few screening programs in many developing countries, especially the lower income countries. And also, diabetic retinopathy screening program has to be built upon an adequate referral system by which screen people could be able to refer for further assessment and treatment. And this poor referral system that exists in most of these countries is also a big challenge to establishing a diabetic retinopathy screening program. So to overcome these challenges, in the last half a decade, there has been an increasing use of innovative measures to be able to overcome the challenges in different health programs. In diabetic retinopathy screening, artificial intelligence has recently been introduced in a number of countries to be able to overcome the challenges I've mentioned earlier, because it provides a kind of tax shift in which you don't have to have ophthalmologists to be able to screen for the diabetic retinopathy, and you need fewer instrumentation to be able to undertake the screening, which means that even in remote areas where there are no sophisticated ophthalmic equipment and there are no doctors, no ophthalmologists, you can be able to do diabetic retinopathy screening. In addition to that, I mean, there are additional advantages to the use of artificial intelligence to implement the screening program. Apart from the tax shifting, which means that you are relieving the ophthalmologist to concentrate on doing more important, more complicated services that they are required to do rather than just screening. You are using people that probably even not be health workers to be able to do the screening. And also it is very fast. It's actually faster for AI screening to be done than even ophthalmologists. And the efficiency is quite remarkable. It also increased the referral compliance, which means that people are able to access the service very easily and they're able to respond to whatever measures in terms of referral that has been done. A study in Rwanda has shown that over 30% increment in referral after introduction of AI. Also, because of the flexibility in the grading, you are able to adjust the threshold which you are going to use for the referral to be aligned with your available resources and referral system. Also, it aligns with your local eye health program structure and diabetic services. Very important also, the AI for diabetic retinopathy could easily include to also screen for other diseases, both eye and other medical diseases like glaucoma, age-related macular degeneration, heart disease, and stroke also. Also of recent, also they've started to use it to even identify early renal diseases. So how does this AI work? So generative AI is able to read the retinal pictures that is presented to it, and then it is able to grade the level of diabetic retinopathy and then able to suggest the referral of the patient. It uses deep learning, which deep learning is a technological term used in computer studies that involves training the machine. Is called machine learning. Now, here you could see a typical algorithm that is used in terms of the screening process. When the images are submitted to the AI, it first makes quality assessment, identifying at clarity, field, and variability, and then it's able to identify the different lesions which it has been trained to detect. Then it's segmented, and then it's able to grade, and then it's able to identify what is the threshold to be referred. In the last half a decade, there has been over a dozen AI platforms that have been developed for DR screening. These are some of them. Of note is the one Selena Iris from Singapore, and the one for Orbis, which is called CyberSight. There is also the one by Google, as well as the Iris by some American team. So the retinal images that are captured, they are presented to the AI, which reads the image. When the images are captured, they are then loaded into the computer, and then they are sent into the cloud where the AI platform is, which is able to read it within few seconds, and then it presents the results, which can then be printed and or sent to the referral center, and then so that the patient can be taken care of. This is a typical picture of a retinal camera where the picture is taken, retinal picture is taken, and then it is got into the computer and then sent to the cloud. This is the typical one for the Orbis. The one for the Singaporeans, they actually have made a customized retinal camera that with non-dilatation and very portable. You'll be able to take the picture. Even the patient himself can be able to take the picture without any assistance, and then it is sent into the cloud in Singapore, where it is read within few seconds, and it downloads the results showing whether it is normal or it is abnormal. These are the typical ways by which the results are presented. The retinal pictures, and they are uploaded. It gives an automated report, which gives the quality assessment. The anomalies identified, highlights is the biomarkers, and then the grading and the recommendation. This is the typical report as per the Orbis, which provides the picture. It provides whether it is abnormal or abnormal according to the threshold that has been sent for referral. This is the American iris. This is how it's presented in kind of multi-color presentation, from green, which is normal, to the red, which is abnormal or severely abnormal, which requires immediate referral. So one of the main questions to ask is that how appropriate and reliable is this technology? Is it better than even using humans, and how useful it is? So there has been a study that was published last year where there was a systematic review of all the AI platforms that have been used across the world, especially in the lower and middle income countries. They were able to get 81 published studies about it, although majority of the studies were in China and in India. But there were some few studies that were from Africa, sub-Saharan Africa, including Kenya, Rwanda, and Zambia. And this is this graph shows the sensitivity and specificity of the different AI platforms as per the providers of the platforms. And you could see that essentially most of the AI platforms, as have been provided and assessed in this study, have achieved over 90% sensitivity and specificity. Looking at the African countries, including Kenya, Zambia, Rwanda, you could see that they have achieved remarkable sensitivity and specificity, which means that they are reliable tools to be used. Now, looking at it in a much more closer way from this particular study, you could see in Kenya there were 2 studies that has shown that both sensitivity and specificity are higher than 90%. The same thing for the Zambian study, which used the Singaporean Selena iris, as well as the Orbis that applied it in Rwanda. Also, it has achieved acceptable sensitivity and specificity. So essentially, this platform of AI for DR screening, it has high efficiency and cost effectiveness because it increases accessibility. As I've said, you can be able to deploy it in very remote areas as far as you have some level of, even if it is intermittent electricity and intermittent internet. Also, because of that, since the patients do not have to travel to the cities to have the AI screening, it results in a reduction in out-of-pocket expenses, which we know in different studies has been a major challenge for people to access health and eye care services. And it improves compliance. As I've mentioned earlier, a study in Rwanda has shown over 30% increment in the compliance of referral of people that need further. And in this age that we are talking about climate change, rapid changes in the environment, as I've mentioned earlier, that yesterday Dubai here had the worst kind of rain and thunderstorm that has ever occurred in the country, disrupting a lot of things. So, in all of us in all our activities, we need to be conscious about climate changes, and any intervention should be able to reduce the carbon print that cause this catastrophic climate changes. So this particular AI platform can be able to reduce the carbon print because it reduces people from traveling a lot. And it is quick and has high quality. It increases the coverage. However, despite the fact that it is quite efficient, very good, and quite effective and cost effective, it has a number of challenges which we need to highlight. The first thing is the capital expenditure to establish it. You need to have internet service, and you need to have a laptop and retinal camera. Even though a number of the AI platforms, they have low cost retinal cameras that can do that. But of more importance is the operational cost, which you would need to provide continuous access to data for transfer of the retinal pictures to the cloud that will have to be read. Another very important thing is that increasingly different countries are coming up with data security regulations, which is really hampering. Several countries will not allow data, even if it is anonymized data, to be sent out to the cloud. So they have these are quite challenging issues, which even in Nigeria, these are one of the things that is delaying the onset of the program. Of course, the electricity and internet outages in areas are quite of concern in areas, and equipment maintenance, AI application malfunction, and patient compliance. So having given this overview, so I'll just take you with the next few slides about what we're thinking to do in Lagos. So this is a program, it is a pilot program, which our organization, Nudbai Foundation, which is a charity organization set up by the ruler of Dubai, Sheikh Mohammed bin Rashid Al Maktoum. It is a charity that's working in the field of eye care only. So we're working with the Lagos State government to establish a free DR screening program so as to prevent diabetic patients in Lagos from going into visual loss. So I think in your minds, or you'll be starting, why Lagos? So there are a number of things that we consider, and because Lagos tick most of the boxes in terms of the immediate requirement for the pilot. It is presumed that Lagos has high burden of the diabetes and of course diabetic retinopathy because of its urbanized nature, and there are no existing large-scale DR screening program within Lagos from the information we got from the Ministry of Health. And Lagos has potential clinical resources in terms of manpower and infrastructure for this. And it has an existing referral structure in which to set up the program, and also technology resources in terms of access to internet wouldn't be a problem. But more importantly, there's the political will. The Lagos State government has shown quite remarkable interest to have this program. So, and when you're going to do any particular program, it's very important you have the baseline data. Unfortunately, Lagos, from the information we gathered from our search and from our discussion with the Ministry of Health, there are no available data, at least not hospital-based data, but community-based data on diabetic retinopathy. So we have to rely on the existing data, the national survey, which I coordinated about a decade, about 2 decades ago. We have to use that data as well as a systematic review that has assessed the prevalence of diabetes mellitus and diabetic retinopathy. So these are the basis on which to project the burden of the problem so as to plan for it. And it is quite of consideration to know that from the projection of the International Diabetes Federation, the number of people with diabetes in Nigeria from now to the next 2 decades is going to rapidly increase. So what is the burden of DR in Lagos? So using this estimates with the population of 24.6 in Lagos, we project that there are at least 700,000 diabetes in Lagos. And since this program is going to target the public health services, we are made to understand from the Ministry of Health that only about 40% of the patients access their health services from the Lagos State Public Health Services. So that puts about 280,000 people with diabetes in Lagos. And using the estimate of the number of people with diabetes with DR, we project that there will be at least 60,000 people with diabetes and about 14 to 28,000 with side-threatening diabetic retinopathy. And these are the existing resources for health and eye health in Lagos on which to build the program. But of more importance here that I want to highlight is the existence of this new document last year that was launched by the Federal Ministry of Health of the National Guideline for Screening and Management of Diabetic Retinopathy, which will guide whatever program is going to have. So it has set out the platform, the foundation to be able to set in whatever diabetic retinopathy screening program. And indeed, our own design of the program aligns with the guidelines of this document. Hello? 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 Hello, can you all hear me?
Yeah,
Hello?
we can hear you. We can hear you.
Okay, fine.
We can hear you, sir.
Okay, fine. So the aims and objectives of the program. So the aim is to reduce visual loss from diabetic retinopathy among diabetic patients in Lagos. And the first objective is to provide this artificial intelligence guided DR program to at least 61,000 diabetes annually. The second objective is to provide clinical assessment and treatment for at least 9,600 diabetic retinopathy affected patients annually. The third objective is to train 24 health personnel in screening and treatment of diabetic retinopathy. And the fourth objective is to deploy this DR screening and treatment tools in 12 health facilities in Lagos. And then the fifth one is to create awareness to at least 300,000 diabetes. So this is a diagrammatic presentation of the diabetic patient journey within this program. We'll try to create awareness to the diabetic patients whom are attending the 10 selected general hospitals. They are attending their diabetic follow-up, where this AI screening will be set in there. So mind you, the AI apparatus will not be set in the ophthalmology clinic, but it will be in the diabetic clinic. That is in the outpatient of the from the AI screen will be given an automatic referral to the 2 tertiary centers selected where they will be assessed, and then provide a treatment which may include intravitreal injections or laser treatment or even surgery. Those that are found to have no significant diabetic retinopathy will be referred back to go for annual screening for next year again. So objective one, essentially 2 retinal images will be taken at the diabetic clinic. It will be sent to the cloud. It will be read within few seconds, and then those that need treatment will be referred to LASUT, which is one of the referral centers, and then given treatment. So these are the projected number of people to be covered. It is cumulative of 415,000 screenings. It is very important to highlight that we've not yet decided the AI application to use, because there are, as I mentioned, there are over a dozen. So, but there are a number of considerations to make in deciding which AI application to use. You have to decide, you have to look at the reliability of it in terms of sensitivity, specificity, rest validated and locally tested. Adaptability, are you able to change the threshold for the referral? Scalability, are you able to use it to also screen for glaucoma, age-related macular degeneration, stroke, or even some of the chronic kidney diseases? Is it portable, easily movable and operable? Is it very simple to use? Is it durable, able to withstand the electrical outages and fluctuation? Is it camera agnostic? Is it able to work with any of the existing retinal cameras? What is the affordability in terms of the operational cost, in terms of data storage within the cloud, and what are the local regulation and security regulations that are required. The objective 2 is those that are referred to this referral centers for where the ophthalmologist will reassess them to confirm the grading and then to provide the treatment. And these are the projected number that we expect for the next 6 years of the program. It is projected that there will be at least 73,000 cumulative consultations. Objective 3, we're going to select 2 nurses from each of the 10 selected general hospitals in Lagos, and then they'll be trained on taking the retinal image. 4 ophthalmologists will be retrained in DR-graded laser application and intravitreal injections. So we intend to have 4 ophthalmologists trained and 20 health assistants or nurses trained. For the objective 4, 10 of the centers and 2 referral centers will be provided with the tools to be able to carry out these activities. The 2 referral centers may have revampment of their existing facilities, including laser machines. Finally, the fifth objective is to set out an health awareness, because as you know, this system will only work if there's a good compliance from the diabetic patients if they come on their regular screening program. So we intend to have a robust health awareness campaign to be able to drive out this message. This is the summarized patient journey with the outputs from health education at the primary centers and the general hospitals, where diabetic patients are being followed up to about 61,000 having AI-graded screening in the 10 general hospitals, to those that are referred to the referral centers, including lawsuit, and then they have the treatment. The program outputs in 6 years is projected to be over 300,000 health awareness, 400,000 DR screening, 73,000 DR consultations, 24 health personnel trained, 12 health centers provided with the facilities to undertake the program. These are the key program indicators in terms of input, process, output, and impacts. Number of educational material, number of health personnel trained, number of screening centers. The interval of the processing indicator includes the interval between referral and patient consultation, number of referred patients found to be false positive. The output indicator are screening coverage, referral rate, referral turnout, treatment coverage. All these have specific definitions with specific numerators and denominators. And then very important in all of the activities that we do here in Nodua, we usually measure the economic impacts of whatever interventions that we are doing, and we also measure the employability and productivity of the people that have benefited. We also try to measure how much reduction in carbon footprints and patient satisfaction. This, according to a very vague and very rough estimate from what we've started to think about, in 6 years, it's going to cost almost $600,000. But if you look at it, this is only like $1.50 per patient in terms of the outputs that you're going to get from that and the benefits. This is our picture of our visit to His Excellency, the Governor of Lagos State, Chidi Sonowolu, in his office, where we discuss about this program with him, with the officials of the Ministry of Health and the officials of the Ministry of Science and Technology. Because of the use of the AI, we had to link up with the Ministry of Science and Technology in Lagos. And these are the references of this presentation. Thank you.
Thank you very much, Dr. Rabi, for the wonderful presentation, for the wonderful lecture. And apologies again, everyone, for the network issue. Please, if you have any questions, kindly raise up your hands or just type it in the chat box and I'll read it out. Thank you. Okay, we have Dr. Ernest. Dr. Ernest, please, you have the floor.
Okay. Thank you very much, Dr. Rabi and the Papers Foundation. And mine is just a little comment and also an appreciation, because there's no doubt about choosing Lagos because it has all the parameters that fit into a pilot study. But I'm also wishing that in the not distant future, other centers can also join. And I also appreciate you, Dr. Rabiu, because when I looked at the personnel that you streamlined the screening to ophthalmology and health assistants. Not being biased, I'm glad that these are the core people that are owning this program, rather than we know the troubles we've had at different places with ophthalmologists, optometrists, and all that. So I appreciate you, Dr. Rabiu. I will chat you for some other information on diabetic screening at our own local level, at our small pace, in our own place in Delta State. Yeah. Thank you very much.
Thank you very much, Dr. Ernest.
Thanks, Dr. Ernest.
We have Dr. Ajayi Obe. Also, Dr. Ajayi, please.
Yeah, good morning. Thank you very much for that wonderful presentation. I wanted to ask, obviously this screening is going to produce work. What is the plan for manpower in the future? Because the truth matters, we start screening, where is the manpower? Even when it comes to ophthalmologists, that's one thing. The other thing is the health assistants. What will be their qualifications once you're going to train? Who are they? And finally, the third question is, we're talking about AI. AI is currently present to everyone. Africa can leapfrog when it comes to Africa. What are the plans for us to own our own data? Own the AI itself, the tools themselves. We have a young group of generation who are actually at par with the counterparts abroad. How are we going to support them for us to develop our own machines? West Africa is, it's ripe for Nigeria to plow into. So I'm just asking this. I just want to ask those questions. Thank you.
Thanks, Dr. Ajayi. So, with respect to the health assistants, stroke nurses, we've seen operating health assistants and stroke nurses. So, essentially, this is a decision to be made by the Ministry of Health in Lagos. What we're intending to do is this program is not going to cause any disruption within the existing structure. So, whatever personnel that are there at the general hospitals that are working in the diabetic clinics, those are the ones that are going to be trained. If they are nurses, if they are health assistant, basically the use of the AI, the good thing about it, you don't even need a health trained personnel. Anyone that can just take the retinal picture and feed in the information about the data of the patient can do it. So even secondary school leavers, you can hire them to do it. But essentially, because one of the cost effectiveness of this program is that you can be able to use the existing manpower to be able to apply. So in short, the decision will be, as I've said, we've only had the initial discussions with the Ministry of Health. When it comes to the final document, then we will know whom they are coming to do that. Then the personnel for the ophthalmologists to do the screening of those that are required. As you will see, we anticipate that the number of people that are routinely screened by ophthalmologists, if they are even screened for diabetic retinopathy, are going to decrease because the AI is going to eliminate a number of them that the ophthalmologist doesn't even need to look at them. So we don't see any much extra burden of work. But even in addition to that, we have discussed with the Ministry of Health in Lagos in terms of additional training. As you've seen, part of the program is also to provide additional training. So we intend to look at the existing manpower, like say in the ophthalmology department of LASUD. When we visited Lagos last October, we went to LASUD, we saw the ophthalmologists, we discussed with them. At that time, one of the ophthalmologists just came back from India, haven't had details training. So as part of the program is to build the capacity of more ophthalmologists that could be involved in this aspect. Then about AI, yeah, it is a very valid question that in Africa we need to wake up to the trend in terms of the in terms of developments of the AI algorithms. We should not depend on people that just from the West that have it and then come and apply it here. So this I guess is a challenge to our academic institutions where AI is being where they have AI studies to be able to guide their students towards applying, trying to have an in-house AI platform that could be used within here, that we can develop it in Nigeria and also even export it to other African countries. I see that like Enes has raised his hand, and then I guess there are some other people. So Adenike, are you going to call upon the next person to ask question?
We don't have anyone yet, sir. But Dr. Koba said, great presentation, Dr. Rabiu. Looking forward to hear the development of the program.
Okay, but I see some hands are raised up. Is it the people that have already asked questions?
Yeah. Well, I'm among the ones that raised a hand. This is Dr. Hassan.
Otumba, how are you? Egarosa.
Dani. I just want to raise my voice. Thank you so much, for honoring us, and to let you know that I really appreciate you. I appreciate your consistency, your commitment to ophthalmology worldwide, and your belief in getting the best out of yourself. If the environment cannot provide it, I'm among those who encourage you to go out to the world there, and you're doing it wonderful. And I'm happy we are benefiting from your word of experience as exposure. And you always remember home to give back to Nigeria, and the Lord will continue to strengthen you. And we look forward to welcoming you back home. And my regards to the family. We're very proud of you, and thank you very much.
Thank you very much, sir. I really appreciate it, sir.
Thank you very much, sir. Do we have anyone with any other questions, please? Okay, Dr. Chimeze. Dr. Chimeze, please, you have the floor.
It seems today is boom. Is there for your surgery?
Dr. Shoduke, please mute your mic. Thank you.
Can you hear me?
Yes, we can.
Yeah, we can, yes.
Okay, fine. My name is Dr. Chimeze Obimbom. I work with National Eye Health Program, Federal Ministry of Health. Dr. Rabiu, thank you for a wonderful presentation. It's been a while. We've not been able to discuss much on this. I know when people started the project, when we are discussing in Singapore. So, using AI in screening is actually the way to go in modern times. But unfortunately, Nigeria has not reached that level yet as of today, and we are working towards that. It's even enshrined in the National Diabetic Screening Guideline. And so my question will be on two things. How do you align this with our national guideline on diabetic screening and management, as well as the diabetic registers that are already existing? Two, those we are developed with the endocrinologist. Two, where will this screening pattern, where do you intend to house them? Because most people have argued housing it in the vitreoretinal clinic or endocrinology clinic. And then the third one would be since you are in touch with Ministry of Health, I know on our own end, we are also seeing how NHIA can get in touch and get the drugs, because screening without treatment is a problem. Since you're in touch with the Lagos State Ministry of Health, can they liaise with the pharma companies to see how they can bring these drugs on board their health insurance scheme so as it can be affordable for the patients, even when the program leaves after 6 years? Because the major problem with Nigeria is sustainability. And we all realize that most of our payments are out of pocket. So without the insurance scheme, it will be difficult for us to sustain this, knowing full well the cost of DR drugs, intravitreal DR drugs. So I think it's something, since you're already liaising, this is more like a comment, since you're already liaising with the commissioner and the ministry, as well as the government, you could let them bring that up into their insurance scheme, so that even after the exit of New Dubai, that treatment will continue. Thank you.
Yeah, thanks, Dr. Chimese. Quite a long time. It's been agreed that the last time we saw, and I just started to brief you about this program, was in Singapore. Yeah, thanks for your just last comment that you made. These are all things that will sort it out, the nitty-gritty about the treatment of the patients and even the sustainability in our programs. Also, we always ensure that there are aspects of sustainability for continuity. With respect to the national guidelines, as I've mentioned in my presentation, we have looked at it and we have tried to align our program within the recommendations of the guidelines. A number of the things in terms of the detailed program, like the standard operating procedure, which will be set out for quality assurance at both the screening stage and at the referral stage and at the treatment stages, we intend to take what is written within these guidelines to apply them, because I mean, they are quite sufficient to be able to ensure that they provide the quality that that we need. Also, as I've mentioned in my presentation, the guidelines also has mentioned some of the key messages for the health education and awareness, and we intend to use such health awareness lines and topics and statements to build them up into graphics, into an acceptable way to administer it to people with diabetes. So in short, we have taken into full consideration the contents of the national guidelines. We actually aligned with it in totality of it. Thank you.
Okay. Before I read the next question, sir, I would love to tell everyone that the CDP form is now on the chat form, on the chat box. Kindly access and fill the form. And also, if you've missed the previous lectures in any of the Kunle Isaiah Foundation Academy series, kindly go to our YouTube page. The link is on the chat box as well. Sir, Dr. Rabiu, we have a question from Dr. Motosho. He said, "Thank you, Dr. Rabiu, for the great presentation. This is a great initiative. With the projections from the screening program, more patients with DR will likely need anti-VEGF. Will the Lagos State government be considering including anti-VEGFs on their health insurance scheme for their patients?"
Yeah, so within the spectrum of the availability and sustainability of the program, we always, when we set up a program, we try not to build a vertical program. We try to make it horizontal to flow within the existing service, and we try not to disrupt existing systems. So we will work with the Lagos State government to ensure the availability of whatever treatment requirements that are required, especially within the insurance sector, because that is the best way to ensure sustainability, as was mentioned earlier. So these are important points which, when we come to the nitty-gritty, as I've told you, the discussions are still at a little early stage, but the concept is accepted by both sides in terms of what will be done and how it will be done. So these aspects about the treatment modalities and others, the standard operating procedures, I think that are going to come in later, and we will take these points on board to ensure that the required treatments and medications are embedded, are included within the existing health insurance system.
Thank you very much. Dr. Enes, your hand is raised up.
Oh, I'm glad to mention that tables no show, the full statistical detail. You should look at the study, look at the result, look at the table, and be able to, decide on what they will talk about in their discussion. Just that table 1, table 3, table 5, it should be, there should be some statistical analysis put there. I'm glad that you mentioned, that, aspect, which is, good, but for this particular, paper, they didn't put p-values, they didn't put their Pascal, what is, value,
Dr. Ajayi,
that table without necessarily reading the paper, which is a short.
Dr. Ajayi, please, are you asking a question, sir? Okay,
I didn't get the point he's making. Can anybody explain to me?
I guess he unmuted his mic and was talking to someone else.
Okay.
Yes. Do we have any questions, please? Okay. Okay. I guess that's all, sir. No questions. Okay, no questions again. Thank you very much, everyone, for joining. And we also apologize for the network issues we experienced earlier on.
Okay, thank you. Thank you.
Thank you so much, Dr. Rabiu, for the presentation.
Thank you, Dr. Rabiu.
We hope to see more of you, sir.
Everybody. Bye-bye. Bye-bye, yeah.